Alcohol-related liver disease. In the UK, alcohol-related disease explains at least half of all clinical presentations of liver disease. It is estimated that 8% of men and 3% of women are problem drinkers, but many more people drink excessive amounts of alcohol, perhaps as many as 1 in 3 men and 1 in 5 women. About 20% of all adult inpatients admitted to general hospital settings are drinking in a hazardous or harmful way. Etiology, pathophysiology, and pathology. Ethanol is primarily oxidized in the liver, Fig 61. Men who drink more than 52 units or 420 grams, 1 unit of alcohol is 10 ml by volume, or 8 grams by weight, of pure alcohol, per week, and women who drink more than 35 units, 280 grams, per week are at increased risk of alcohol-related liver disease, ALD. The 3 most widely recognized forms of ALD are alcoholic fatty liver, steatosis, acute alcoholic hepatitis, and alcoholic cirrhosis. The histology of alcoholic liver diseases is shown in Fig 62. Epidemiology. At least 80% of heavy drinkers develop steatosis, 10 to 35% develop alcoholic hepatitis, and about 10% will develop cirrhosis. Clinical presentation. Minor alcoholic hepatitis may be asymptomatic, with elevated serum transaminases as the only abnormality, and many people are diagnosed when they have routine liver function tests as part of a medical checkup. Severe alcoholic hepatitis presents with hepatic encephalopathy, jaundice, renal failure, or coagulopathy. Other than those who present with decompensated liver disease, patients tend to have nonspecific features such as nausea, vomiting, abdominal discomfort, or diarrhea. They may also present with other sequelae of alcoholism such as pneumonia, rib fractures, head injury, pancreatitis, neuropathy, or heart failure. Physical signs. This depends on the severity. Mild and moderate alcoholic hepatitis causes tender hepatomegaly with jaundice in 10 to 15%. Severe alcoholic hepatitis causes jaundice, ascites, hepatic encephalopathy, and rarely a hepatic brute. Parotid gland enlargement and testicular atrophy are sometimes seen. Investigation. Assessment of severity. FBC, there is often a leukocytosis, more common with viral hepatitis, and a macrocytosis. An initial low platelet count is seen with acute alcohol use in the absence of portal hypertension. Low-grade hemolysis is common. Prothrombin time is an important prognostic marker. Liver function tests reveal aspartate transaminase, AST, usually greater than 300 U/L, greater than alanine transaminase, ALT, in alcoholic liver disease. Alkaline phosphatase is often elevated, with levels up to 3 to 4 times normal in the absence of pancreatic disease, i.e. lower common bile duct stricture from chronic pancreatitis. NB. Transaminase levels greater than 1000 U/L are seen if there is associated paracetamol toxicity, which can occur with doses of as little as 4 to 6 grams. Assessment of chronic liver disease. Alcoholic hepatitis can coexist with other chronic liver diseases, e.g. hemochromatosis, hepatitis C, and hepatitis B, which should be screened for as appropriate. Abdominal ultrasound is needed to exclude biliary obstruction and signs of portal hypertension suggestive of cirrhosis. Liver biopsy is diagnostic of acute alcoholic hepatitis, but because of abnormalities in coagulation is not often performed in the acute context. In the long term it is needed to establish the extent of hepatic fibrosis. Differential diagnosis. Drugs, viral hepatitis, and autoimmune liver disease. Treatment. This will depend on the presentation but with specific regard to alcoholic hepatitis and alcohol addiction. Short-term. Corticosteroids should be considered in severe alcoholic hepatitis as long as there is no evidence of infection or renal failure. Long-term. Abstinence, psychological input and counseling both reduce readmission rates. Drugs, acamprosate and naltrexone, 12 months, may reduce alcohol dependence. Disulfiram should probably be avoided because of side effects. Complications. Ascites, hepatic encephalopathy, septicemia, hepatorenal failure, and chronic liver disease. Prognosis. Patients admitted to hospital with alcoholic hepatitis have an overall 15% mortality at 30 days, but those with severe disease, hepatic encephalopathy, jaundice, renal failure, or coagulopathy, have a mortality closer to 1 in 2. There are a number of ways of quantifying an individual patient's chance of surviving. The Maddrey discriminant function involves a formula including the prothrombin time and serum bilirubin, with those scoring highly, worse, often considered for a trial of steroids. The Glasgow Alcoholic Hepatitis Score, GAS, depends on 5 variables: age, white blood cell count, urea, prothrombin ratio, and serum bilirubin, and appears to perform slightly better. Overall survival at 5 years is 60% if the patient remains abstinent, falling to 40% if the patient continues to drink. The development of complications of cirrhosis reduces life expectancy. A first variceal bleed has an average in-hospital mortality of 20 to 30% and those with ascites have 50% mortality at 2 years. The treatment of hepatocellular carcinoma is usually palliative. NB. Remember that although alcoholic liver disease has a poor prognosis, each patient should be assessed and managed on his or her own merits. Do not deny patients intensive care or organ support just because they are alcoholics. Prevention. NB. Men should drink no more than 21 units of alcohol per week, and no more than 4 units in any one day, whereas women should drink no more than 14 units of alcohol per week, and no more than 3 units in any one day. Pregnant women who drink 1 or 2 drinks of alcohol, 1 or 2 units, once or twice a week, are unlikely to harm their unborn baby, although the exact amount that is safe is not known. Psychological input and counseling, including referral to Alcoholics Anonymous, is indicated when there is alcohol misuse. Disease associations. These include hypertension, alcoholic cardiomyopathy, chronic pancreatitis, duodenal ulceration, peripheral sensory neuropathy, cerebellar atrophy, cerebral atrophy, Wernicke's encephalopathy, and Korsakoff's dementia.